My name is Richard Preece. I'm the lead for quality in Greater Manchester. We have quite an unusual kind of leadership structure here, at least in NHS terms. So we don't formally have the same roles that you might see on a large NHS trust. So I happen to be a physician, so I end up being the medical director as well. I'm not going to assume that everybody is from Greater Manchester or knows the geography. You probably do actually, because I suspect those who were going to travel a long way didn't arrive. But what you'll see here is two images of Greater Manchester. It's not all industrial, it's not all urban. That's a photograph from Gloucester looking back towards the city actually. And as you can see, we've got a significant number of areas which are fairly rural. Actually, you wouldn't be able to take that photograph today because the Woodend Pass is closed. But if you were intended to go home that direction, well, that's what it looked like 2 weeks ago on the way to Sheffield. So just to give it a sort of sense of scale, if I may, across the conurbation we have 10 localities, so that's 10 council boroughs, and we have a population of about 2.8 million, but it depends what we're talking about. So if we talk about our cancer arrangements or maternity, then we sort of also look into East Cheshire. That takes it up to close to 3.2 million. And the importance of that, I guess, in terms of what we're trying to think about today is that that's kind of sufficient population to pretty much consume all your own smoke. Nearly everything we need to do in terms of health and social care for people in Greater Manchester is done within Greater Manchester. There's a relatively limited flow of patients outside of the conurbation. We can do most things here, but it isn't just about the large provider organisers. It is about the granularity of different providers as well, which goes right into primary care, and that's really important because when we're trying to think about quality improvement, we're trying to think about this in a systems approach. The number of organisations, the number of people, the number of the people in our workforce really matters in terms of trying to get a broad picture. And it is very varied. So what does devolution mean? Well, you know, these are the sort of principles. There are only two things I really want to draw out about this. Firstly is that we haven't got devolution in the way that everybody else might kind of know it. So there's no statutory underpinning of devolution for Greater Manchester. Of course, we've got a mayor now, although at least technically Andy's not got a remit for health and social care. Try telling him that. And importantly, though, we don't have devolution in the same way we might see it in Scotland, for instance. It is done through a series of delegations, and that's quite a powerful thing too, because you think, well, maybe having the kind of statutory authority will be helpful, but actually it's much more powerful to do things by partnership. And already today we've talked about engagement and how we get people to work together to achieve common aims. We got devolution in Greater Manchester because we asked for it, because there's a very long heritage of people working together, and that's probably exemplified by the airport, where the local authorities have all worked together in managing that for more than 50 years, and it's one of the most successful airports in Europe. And then the second part of it is we're not trying to create this great big kind of hub that does everything. Subsidiarity is king for us, and what I mean by that is we don't do things at the GM level that we can best do at locality level. And actually what we're trying to do increasingly is not do things at locality level that we can best do at neighbourhood level. And neighbourhoods for us are populations of about 30 to 50,000 people, usually being looked after day to day by a small number of general practices. So we're increasingly trying to give that sense of local ownership, and that's really important, because when it comes to understanding the needs of the population, then it is that engagement right down into neighbourhoods where you really get the best of community groups, the voluntary sector, and a really rich understanding of what we might need to do to help the population's health improve. In terms of trying to design a system solution, quite a lot of the work that we've been doing over the first 2 years of devolution, and I know we've talked about it for a long time, but actually it only started on the 1st of April 2 years ago, is really to create the organisational structures, the ways of working that allow it to happen, that we can do things effectively as a whole system, and indeed we can make decisions relatively quickly. And that takes time, and probably the biggest and most important piece of the jigsaw, which is the commissioning arrangements for Greater Manchester, have only just gone through our governance systems. Designing a solution is not straightforward. There is no evidence base out there that really can inform what we might call system leadership. Actually, if you start to dig into the literature, what you tend to find is they're not really talking about a system on the kind of scale that we are here. It tends to be, even with models of distributed leadership, within single organisations or single small groups of organisations, to try and do it across the whole of a structure of the size of Greater Manchester is quite difficult. And there are some precedents that can steer us, but mostly we have to work it out for ourselves. So it shouldn't be a surprise, for instance, that we've changed the governance arrangements 3 times in the 16 months that I've been here. And when I say change, we've kind of just tweaked them and refined them, because it is a bit of a journey. When we talk to colleagues nationally about how they might be going down a similar journey, we can't impose a destination. We have to do it one step at a time, and every time we take a step forward and we get that embedded, we then realise we want to take another step. So our governance evolves, and most importantly in that is this the sort of structures that allow that to happen in the localities, and that's quite tricky, not least because legislation doesn't necessarily make it easy to create the organisational structures that we would like. So we have done a bit of reshaping of large organisations. We've seen the merger of 3 Manchester CCGs, we've seen the joining up of 2 of the mental health trusts, and most recently the 2 Manchester hospital trusts have come together. So there has been some reshaping at that level. But key to the delivery of what we're trying to do here is what we call locality care organisations, which is the collection of community-based services for our population in each of the 10 boroughs, the 10 localities. And actually trying to create those is not straightforward, because the current statutory framework doesn't make that easy. So we end up with hybrid arrangements where it's pulled together by a series of agreements and maybe hosted by a single organisation. And alongside them in the localities, creating strategic commissioning functions, and they're just about in place now, but again with lots of agreements in place about how they'll work together, because local authorities and the NHS cannot delegate to each other all the authority to make separate decisions. So in each of those localities we will have a strategic commissioning function, and they're about to kick off pretty much everywhere over the next month or so. And they will commission at that strategic level all health and social care. But what you will find is that each of the people that heads up those organisations is dual appointed. So we'll have a contract with the local authority, have a contract with the CCG to enable the decision making to proceed. So it is complex. Fundamentally though, devolution, and I'm asked this a lot, is what is it all about? And it's about accountability. So it's very easy when we sit in this room and we're all having a bad day, and we can blame it on Whitehall or Leeds or NHS England or Improvement or CQC. It's somebody else's problem. And that's quite convenient actually, but what we said in Greater Manchester was that we knew our population best, and we were best able to meet the expectations of our population. So it gives us the opportunity to do that. So accountability is about it's about keeping promises that we've made to our families, our friends, our neighbours, our colleagues, the people that walk past my office every day. It is a very direct sense of accountability. And when I'm talking to my colleagues in the sort of leadership team for GM, that actually what you get in common is that huge sense of we've made a promise and we're here to deliver on it. And that's not unique by any stretch of that imagination, but we all feel quite passionate about it. So one of the things that you would see if any of the leadership team were here today is that we feel quite strongly about what we want to do, and it is, in my view, very much down to the fact that we've made some promises to the people around us, and it's our intention that we should keep them, even though they might be quite challenging. In terms of trying to establish a quality improvement model for Greater Manchester, that I thought would be straightforward, and it surprised me and worried me when I came here that it wasn't going to be straightforward, and maybe I was a little bit naive, but I have worked in this domain for the last 15 years and I kind of think I know a little bit about it, but actually it was probably the biggest challenge that I faced last year in trying to get everybody onto the same page. What I mean by that is that everybody has their own view about what quality improvement should look like. So we all have our preferred philosophies, our preferred tools, our preferred ways of doing things. And when they work for us, our views can be quite firmly held. So if I look across Greater Manchester, I see organisations where quality improvement is exemplified by a passion for improvement science, or academic excellence, or workforce engagement, or sanctions and incentives, or whatever it might be. And in all those cases, actually, they might feel that it's worked for them. So getting everybody onto the same page was an extraordinarily difficult thing to do. And we did want to do it as a system, so I'm going to go through this image, but it's really just to say that you know, it is such a large system. It does behave in quite organic ways. So I quite like biological metaphors. So when other people talk about biological metaphors, I think it's worth sharing back with you all, so forgive me. In trying to establish an improvement model that we could share across Greater Manchester, I was struck by what they did in Baltimore. And that's not because they introduced a system which went across health and social care. In fact, it was just for the Johns Hopkins group, and that's predominantly hospitals and some sort of primary care centres. But the bit that struck me about this was fractals, and I like science and I like numbers. And fractals are all about self-similarity, about things in common. And that's quite a good biological metaphor for what we're trying to do. So here's a fern, and a fern is a really good fractal because the little bits of the fronds look like the bigger bits of the fronds look like the whole of the frond. And the idea with this is that actually when you look at a model of quality improvement, whatever you look at, whether that's at a ward level in a hospital or a care home or a whole hospital organisation or a community team in mental health or whatever it might be, that actually you should see similarities there that give them a common language and a common purpose. And this is really important because one of the things that struck me when I came into this role was you know, we've got some parts of our system where, at least in CQC terms, it's outstanding. But actually we've also got parts of our system which are inadequate. One of the nice things happened today is that the CQC report into Penn IQ was published today and have been rated good, which is fantastic. But that wasn't the case when I arrived 16 months ago. But nevertheless, what I see as an example is you've got Salford Royal, which is an outstanding rated hospital trust, surrounded by social care, which is some of the lowest rated, or has been some of the lowest rated in England, and it's improving. But for me, it's that image of the luxury ocean liner cruising across the Bay of Biscay in a Force 10, which is, you've got that bit of excellence, that bit of something which is, you know, we see as being very good, surrounded by some really tricky things that we need to sort out. And for those of you who've not travelled across the Bay of Biscay in a Force 10, and I didn't do it in an ocean liner, I can assure you it's not a very pleasant experience. And so how can we reconcile in a system where everything is at least good? And if I use that language of CQC, you have to forgive me. But it is the notion of, it's really not much point in having a hospital service that then hasn't got the services in the community around it that enable it to perform as a whole system in the most effective way. So the similarities, well, you can read them for yourselves, but most of them are pretty obvious. And they're pretty obvious in that if we're going to have a quality improvement programme that somehow cuts across everything we do in Greater Manchester, we've got to have some principles that lie. You can read it for yourself if you like. But key to this is the idea that we've got a plan and we do something. And just to emphasise, this is not about a great big plan for quality improvement for Greater Manchester. Subsidiarity rules. So this is about making sure that when we look across our plans and programmes for Greater Manchester, all those things we want to do, all the things that we're looking at within individual organisations and providers, is to say, well, actually, have you got the common ingredients? Because if you have, then you can have a conversation with colleagues locally and understand that you're all on the same kind of journey and how that can dovetail together. And that's not happened until now. But now we've got this improvement framework, which we approved through our own governance structures in September. there's now a conversation going on, which is to look at things that we're doing through that lens and say, actually, do things sit together in a coherent way. So it's not to impose a solution that wouldn't work. The way they do it locally has to suit them. But it is to say you should be able to articulate in that in a way that everybody else around you understands it, so we can go on that shared journey. So, let me just get finally on to it. Okay. So, key to that, of course, is what I call communities of practice. I know there's a bit of disrepute that goes with this term, but all I'd say about that is that the reason I wanted to share that today is that we've got loads of communities of practice, and we've not tried to impose a single model of how we do it. So we've got operational delivery networks for stroke, we've got an alliance for orthopaedics, we've got clinical networks for critical care, we've got a whole raft of strategic clinical networks, some that existed when I arrived and some that we've created. And so the list goes on, but it is this idea of how do we engage with the people around us. And when I use clinical, I'm using it in the Greek sense of by the bedside. And this is really important because this is not about clinician networks, this is about clinical networks. So this is about broadening the considerations that we recognise when we put teams of people together and ask them to help us with improvement, that actually it needs a whole different, a whole range of skills. It's not just about doctors and nurses and other clinicians, it is about social workers, it is about commissioners, it is about finance, it is about a whole range of people that can help us with the programmes that we have, and starting on a journey where everyone sees that they might have a role to play in improvement. So it's about broadening the concept so that it meets the requirements of a system level improvement that cuts across everything in health and social care. Of course, we do have to struggle with this idea of vertical leadership and horizontal relationships. So at the top level for GM we have the Health and Care Board. That's made up of representatives of all the large NHS organisations, the CCGs and the provider trusts. It's also the local authorities, but it's also other representation, including key to this, representation from primary care, and there are a number of people from primary care, and also input from fire and the police, which reflects the orientation towards a wider view of public sector reform. And one thing that happens when you're in the room with the local authorities is their view of some of the things that we might want to do in health is slightly different. So it's quite good for me in the sense that I've spent most of my life trying to see work as a really key health outcome, and actually you don't need to make that argument with the local authorities, because for them employability and enablement are just bread and butter, and I've not always found that to be the case with NHS colleagues. So we do have to have that vertical authority, that management authority, to make things happen so we can hold people to account. But most importantly, it is about partnership relationships, about that cuts across the networks, which is the horizontal part. Just wanted to try and give one example, if I may. Partly as a bit of fun, well, you may not think it's fun, but I do. But also to try and sort of bring it to life with some of the challenge we've got. We made out some really big promises at the start of the devolution journey when we were asking about it, which was in a document called Taking Charge. And if you're going down this path, it's a fairly easy read, especially if you read the summary version. But what it does is it starts to lay out some principles of the kind of things that we might want to do. And one of the things that we said there was we said a few, I think it was 5 clinical outcomes where we really wanted to make a difference over the next 5 years. And they were things like reductions in mortality from cancer, premature mortality from cancer, and improvements in neonatal outcomes. And one of them was reduction in serious injuries from falls. So I just wanted to look at that, because one of the things that we've got plenty of in Greater Manchester is poor outcomes. We've got some great services, we've got some great outcomes, but we've got more than our fair share of poor outcomes, and we need to do something about it, and that's why we started this process. So this is injury from falls, and this is the Right Care data. And the reason I share this is because Right Care compares our CCGs, and this is the pre-merger of the Manchester ones, which is there's more than 10, with the most similar other CCGs. So what it means is that, if you're in a difficult, deprived area with poor population health and well-being, you're at least getting compared to a similar area. So when we're red on these, we're really red, because if we were compared to the best or even to the national average, we will be miles behind. So what it says is we have a lot of falls and a lot of people get injured, and those of us who know about these things will recognise that A is not very good for your immediate health, but for things like fracture of the hip, it's associated with high rates of serious morbidity and mortality. So this is my new favourite location in Greater Manchester, which is a bridge over the River Irwell. And it's my favourite location because it is equidistant from 3 of our emergency departments. To the northeast, North Manchester General, to the southeast, Manchester Royal Infirmary, and to the west, Salford Royal. And it's not that far away from here, but it's almost exactly 3 miles walk to either of those. And the point being that, you know, if you get injured on that bridge, someone's got to toss a coin. Can you get a 3-sided coin? I don't know what you toss to get between 3. But anyway, let's imagine a 3-sided coin that we're now tossing. Should we go northeast, southeast, or to the west? And we would hope, you know, as consumers of health service, that we might get the same level of care wherever we might go. And of course, we will be horribly wrong. Oh, that's not projected very well. Is it on there? My apologies for that. Not quite sure that's the case. That little red box is supposed to surround Salford, Manchester Royal Infirmary and North Manchester. It projects well at home, but not here, but then that's probably the cold weather. But what you will see that when you get picked up by your ambulance with your fractured hip is that you will be pleading not to go to North Manchester, thank you very much. Surgery on the day or within 24 hours really matters with hip fracture, and it really matters because, as you'll see from when people go home, it is associated with very broad variations in whether you get home or not, and that's after 120 days, 4 months. And what it doesn't show you on this slide, but the data is all there if you want to go and have a look at it, it's also associated with significant mortality. So if you fall over and fracture your hip, you really do want to go somewhere where they're going to fix it properly very quickly. And this is publicly available information, but I'm pretty guessing the public don't read this, and I'm pretty sure when you're there, you know, writhing around in agony on that little bridge, you're not going to get your phone out, consult the National Hip Fracture Database, and then plead with the ambulance crew to take you west as opposed to northeast or southeast. But it does really matter, and that's the level of challenge we've got in the system in terms of how do we improve and how do we engage with the public. And although I share this just kind of for a bit of interest because it lays down some of the challenge we've set, because we said we're going to reduce the number of serious injuries from fractures, serious fractures from falls by such a large number. This stuff really matters, and when we're trying to set priorities, this stuff really matters. But alongside that, if I fall over on that bridge tomorrow, I know what I'm going to be asking. And what it also highlights, and most importantly for me, is that our public, our population, our consumers are really badly informed about variations in care. And quality improvement here has to be about not just giving them a consistent offer, but also making sure that they know that that offer is consistent. Because I really would not want to be going northeast if I fell over there tomorrow. So the point there is it does matter. The other thing about it is that red star, which is my bridge, so it's my bridge now, actually personally only you can see that, is in Salford, so it's in the Salford locality. But you can quite easily be taken into the Manchester locality, to one of the two EDs there. And actually what happens in the localities in terms of support, return home, and indeed community services is also varied as well. So I've just picked out a few metrics just for fun really. But actually there's a bigger backstory there, which is about how do we work together across the conurbation to make sure that not only the immediate treatment, that immediate surgery is right, but also the follow-up within community services right so people get home. And the only way for us to do that will be through locality care organisations that we're establishing at the moment. So just to wrap up, you know, I really wanted just to give a flavour of what we're trying to do with quality improvement here, and not pretend I've got all the answers because I definitely haven't, but really just to start to, you know, share some points of interest. Well, at least I hope they are. And out of this is about getting the shared understanding. So this model that we've put in place, which cuts across the whole of our system, across the health and social care, I'm quite proud of, and I'm quite proud of it because nobody else has done it. Now you might stand and correct me if you like, but I've looked high and low internationally for a model to copy, and I've spoken to lots of people since we brought it in, and I don't think anybody's done it across the whole of health and social care. There aren't many countries where you could do that, but it's not there. And even with the examples that perhaps we heard about this morning, like in Canterbury, they haven't done this either. And the final thing is to emphasise this concept of accountability, which is that is, for me, the embodiment of devolution. This idea that we've said we can do this better because we know our population better, we know our services better, we can bring people together better. But actually then we've got to deliver on that, and it is about delivering to the people around us. So thank you very much.
Thank you.